There were some differences to working here that I could see even before I was working here, particularly with the clientele. So the practice that I work at is a semi-suburban / central kind of a urban practice, but very highly educated population, relatively well-off clients. So you get a certain taste of medicine from that, and there are certain other parts of or ways of treating people, particularly when you bring lower socioeconomic factors into play that I didn't have a lot of experience of at where I was working. So this did in some ways flesh that out and give me a chance to work with other people whose paths I might not normally cross in my normal work. I've got probably about 300 patients to illustrate that here, but because very much so they're people who often have been at other practices and couldn't afford to stay there, so they cannot pay their bills. They'll often have multiple medical conditions, so they not only can they not afford to go, but they need to go more often, and so it's just that double whammy of complexity that makes it a real struggle for the clients here. We do pride ourselves on quality medical care here, and I think there may have been from the general population there might be concern that it's a free medical centre, people will get lesser care, but that is very much not the case. In fact, I think the reverse is true, and we really pride ourselves on that because we control our waiting lists, our enrolment list, should I say, we know how much time it takes to see patients. We concentrate on really giving them optimum care, which means, because, as I say, this increased complexity means a lot more time. For example, we have generally had a policy of trying to see our patients every time we do prescriptions. Now, that's not standard within a medical practice. Most people will try and see their patients as little as possible if they are well, and do repeat prescriptions as much as possible. Now, obviously there can be safety issues there, but that is brought on by a commercial driver. So if you don't see your patients but you still be getting paid by the government, the capitation, then you're potentially you can have more patients. Whereas here, because we say we want to see them every time, we want to build up that continuity, it gives a very different flavour to how they are managed medically, both in terms of that continuity, but just that we can do so much more for them. The example would be, seeing a patient, let's say they have asthma. Now, asthma tends to be pretty well controlled, so when it is well controlled, and so you may not need to see patients in standard primary care for a year or two. They might just need re-top-ups of their inhalers every now and then. But by seeing the patients here with their asthma, say every 3 months, might be maybe more like every 6 months, because they might not need their inhalers that frequently, but then you have an opportunity to talk to them about their smoking, which is why their asthma is so poorly controlled, or about their housing, or various other social factors which play into their health conditions. And indeed, you build up that relationship, so they start to know you better, you start to know them better, and you can start to tackle some of the other things they wouldn't even talk about to you if they only saw you every 2 years. So that's kind of how it plays out in practice here with building up these relationships.